Hello guys, welcome back. Hope I'm audible and visible. Today we're going to discuss something in a very relaxed manner. I have quite a few interesting cases here, which as usual, like yesterday's case, quite a few of them are from the practice, whatever you've seen. Yeah. And few of them are from Robin's pathology book. Let's learn and let's extrapolate and we'll see different cases from different organ systems that we'll have an overall understanding about how to solve a case. And if just an image is given, how to extrapolate with the help of few subtle findings, what you're going to learn from today. Fine. To start with, there will be a price hike from today. So if you want to subscribe to Unacademy before that, go tonight. You can subscribe using any code, whatever you have. If you don't have a code, you can use PathoCups. And there's a 6 plus 2 months offer available as well. So if you subscribe for 6 months, you get an extra validity for 2 months. And there are specified tailored batch as per your needs, be it FMG, be it your NEET PG, or be it an NICT exam. And these are the free test calendar. You need not subscribe to attend them. You can just give a go by looking at them. If you feel any of the subjects you feel is difficult, please have a look at them and attempt more, practice more, and improve for yourselves. Fine. And there's an UPSC CMS batch going on. If you're targeting upcoming UPSC exams for the same medical categories, you can go and have a look at that. And there are lots of special classes will be scheduled. From my side, for the next month of June, we'll be starting, we'll be first completing for the FMG classes, which I promised that I'll be taking about kidney and a little bit of lungs. We'll finish that. Then we'll have a different schedule start. We'll start Robins from scratch and try to complete Robins as much as possible. Fine. So let's go ahead and go with our case. The discussion is as usual, like yesterday what we saw. We're going to discuss it slowly and steadily. I'm going to give you an image and I want you to comment on whatever comes to your mind, right? I hope the video is clear. Fine. Okay. So this is the first case. As I'm not going to give you any leading history here, I'm just going to display a biopsy. I want you to comment on the biopsy, whatever you see. My first question is, what biopsy is this? The biopsy here, what biopsy is this? So if you look at this, that's definitely a bone marrow biopsy, right? My first question here, it's a bone marrow biopsy. This is a low power image of a bone marrow biopsy. Whenever you're going to see a bone marrow biopsy, there are a few things which I want you to keep in mind. First, comment on the adequacy of the biopsy. Last NICT exam had a question on adequacy of your thyroid aspirate, right? The adequacy of bone marrow biopsy, I should have approximately 6 bone marrow spaces. When I have approximately 6 bone marrow spaces, obviously there are a few exceptions, which I mean that if I'm able to pick up the diagnosis in only 1 bone marrow space, that should be enough for me, right? So for an adequate bone marrow biopsy, I should have 6 bone marrow spaces and it should be about 1.5 centimeter in length. The true cut biopsy should be at least 1.5 centimeter length and should have 6 bone marrow spaces. Because when you take a bone marrow biopsy, the length alone is not sufficient. Because let's say that you take it from the iliac spine. If you go with tangentially, you'll get only the cortical area, the cartilaginous part. So the length might be there, but I will not have a bone marrow space. That's why both are required for me. It should be 1.5 centimeter length and I should have at least 6 bone marrow spaces. Preferably 10, but 6 should be more than enough. That's like a minimal requirement for me, right? As a first thing. But as I said, that if I can pick the diagnosis just based on the microscopic finding, that also should be more than enough, right? Now let's look at this. I'll just give you only one history here. Let's say that this is a patient who is 26-year-old. This 26-year-old person's bone marrow biopsy. Comment on it. The first comment which I want you to tell is about the cellularity, right? Welcome, MSS. So tell me about the cellularity of the biopsy. Is it normocellular, hypocellular, or an hypercellular biopsy? Comment on whatever comes to your mind. Normo, hypo, or hyper? This at least is definitely a hypocellular biopsy, right? So how do I comment on cellularity in case of a biopsy, in case of bone marrow biopsies? I'm sure you must have known the easiest way to pick up cellularity. The easiest way to pick up cellularity is the age, right? So the normal cellularity of a bone marrow is given by the formula 100 minus age of the patient. So let's say that this patient I told is a 26-year-old person, right? A 26-year-old person should have at least, let's say, around 74% cellularity, approximately, right? So if let's say that patient's age is 50 years old, I should have 50% cellularity, which means let's assume this are my two bone marrow spaces. There's a bone marrow space. In this, at least approximately 50% I should have cells, and the rest 50% can be fat. Again, it cannot be divided like this. It will obviously be intermixed. Approximately 50% I should have cells. In a bone marrow biopsy, I cannot give the exact cellularity. I can give a suggestive cellularity. That's all. Fine. So with this formula, in a patient who is 26-year-old, I should have 74% cellularity, right? So with this, I'll go and have a look at this image. This cellularity is normal or hypo or hyper. Like yes said, definitely this is a hypocellular biopsy, right? The easiest way to pick up the cellularity, as I said, if you look at this bone marrow space, this space alone, actually I don't have any cellularity at all, right? It's completely kind of acellular. Though it's low power image, I don't know what is there here. Look at this. When you look at these parts, maybe I can say yes, there's a little bit of cellularity, but still it's not amounting totally for 75%. Definitely no, right? Maybe I'll have 25% cellularity, 75% here it looks acellular areas, right? So here my first possibility is an hypocellular biopsy. It's an hypocellular bone marrow biopsy. So if it is an hypocellular bone marrow biopsy, tell me your differential diagnosis. What all you will think of when the bone marrow is hypocellular? There are lots of differential diagnoses for hypocellular bone marrow. We'll look at the differential diagnosis for hypercellular and normocellular bone marrow as well. Tell me what all comes to your mind for hypocellular bone marrow. At least the common ones. The common ones which comes to your mind in case of a hypocellular bone marrow. Anyone? Perfect. SS started with one thing. Aplastic anemia is definitely one of them. Anything apart from aplastic anemia which you think which might have an hypocellular bone marrow? There are quite a few of them which can have an hypocellular bone marrow. Anything? Aplastic anemia is one of the leading causes for sure. Aplastic crisis, yeah, I can take aplastic crisis, but it's a transient process, like it's as the name says, the crisis. So MDS definitely I'll consider. Again, not all MDS will have hypocellularity. MDS actually is hypercellular. There's a hypocellular variant of MDS that will have hypocellularity. Perfect. Your myelofibrosis, the cellularity will be less. But in myelofibrosis, the entire place is going to be replaced by your fibrotic tissue, right? Then if I have a storage disorder, let's take Gaucher's. In Gaucher's, what happens is the entire bone marrow will be replaced by my macrophage. That will have hypocellularity, right? So cytopenias and hypocellular bone marrow, I have few differential diagnoses. When I have a hypocellular bone marrow, few things which I want you to think of. As you guys correctly pointed out, first I'm going to think of aplastic anemia. Again, MDS, yes, few variants of MDS will be hypocellular. In an ideal condition, I will think of hypercellularity, more cellularity for a myelodysplastic syndrome. MDS, myelodysplastic syndrome. I will not think of an hypocellularity. Few variants, yes, definitely low. Again, few variants of leukemia also can have hypocellularity. There are hypocellular AML presence. Again, a very few variants of them. Again, when I have any other extra hematopoietic tissue, right? When I have a bone marrow metastasis, I can have low cellularity. When I have a storage disorder, I can have a low cellularity. When you have infections, I can have low cellularity. Like for example, I'm having a bone marrow filled with tuberculous granulomas. Definitely my cellularity would be less, right? Satwik, HCL, hairy cell leukemia will come under the purview of secondary myelofibrosis. When I say myelofibrosis, most of the causes comes under the umbrella, right? Okay. So these are the possibilities. Now, looking at this low power image, tell me what comes to your mind. What do you think is the most likely diagnosis of this image, considering our different differential diagnosis? I'll go to the higher power for sure. It looks more like a fatty replacement of bone marrow. Yes, kind of looks like your aplastic anemia, right? That will be the first thing which should come to your mind when you look at this, right? I'll go to higher power. I want you to look carefully and say, is it really an aplastic anemia or something else? If it's aplastic anemia, I want you to tell why you called it an aplastic anemia. If you think it is not an aplastic anemia, I just want you to know, want you to again justify Why do you think it's something else? Because there is a very classical clue here. I hope you'll be able to pick it up. Is it aplastic anemia? Anyone? You can comment on whatever comes to your mind. There's no inhibition here. I just want you to think, extrapolate whatever you know. An old age present like this. We'll go to it, Sadhvi. We'll go to it. As I said, the history of this patient is 26-year-old. So I'm not going to think of an old age patient here. Right? So I gave you a history, 26-year-old. 26-year-old will not have that, right? It doesn't look like an aplastic anemia, isn't it? Because if it is aplastic anemia, I should have the entire bone marrow replaced by fat. But do you see fat here? I'm not seeing fat exactly, right? I do see fat, like let's say this part is fat, this part is fat, here is fat. But in between these areas, it's not adipose tissue. I don't see adipose tissue. If you want to zoom it up, I do see here and there scattered fat for sure. But I do have a little bit of extra something else also here, right? So if it is not a bone marrow biopsy, let's assume it's a biopsy of your colon. What will you comment on this? The colonic biopsy or it's a breast biopsy? What will you comment on the background material? Again, I want you to think. What will you comment on the background material if it's a colonic or your breast biopsy? Can I say it kind of looks like a mucin change? Will a mucinous carcinoma of the breast or the extracellular mucin of a colonic carcinoma look like that? Is that possible? Kind of possible, right? So it has something glistening material in the background. It's not fat, it's not clear, it's not empty, right? I do have few retained foci of hematopoietic tissue. These are my retained foci of hematopoietic tissue. But the background is bit mucinous. It's stroma, right? It's stroma. It's having some stroma is having some change, right? Now I want you to come to a conclusion. It's not an aplastic anemia, but I'm having a stromal change which looks like a mucin. So there is a particular condition called as gelatinous transformation of bone marrow. The entire discussion here is for the diagnosis. This diagnosis might be new for you. I just want to introduce a new term for you, which is gelatinous transformation of bone marrow, and it's a classical case of gelatinous transformation of bone marrow. I'll tell you where we can see them. We can easily come to a confirmative diagnosis as well as the etiology here, okay, of the bone marrow stroma. Like Sadhu said, it's a stromal change. It's not the problem with the cellularity, fine. It's just a gelatinous transformation of bone marrow. Okay. So here I do have few other names. It's also called as a serous atrophy of the bone marrow because I don't have any of the cells in there. It's kind of atrophy, right? Actually, there's one more change. That's where they discover them. It's also called as a starvation marrow. The starvation change in the bone marrow, which means the bone marrow is not having enough food or nothing, so it's been replaced by something else, right? Means when I have a patient who is extremely cachectic, right, not having good amount of food, can I say the peripheral fat will be mobilized? When you see a patient with kwashiorkor marasmus, at one point of time you must have read that the last fat in the body to go is the buccal part of fat, right? You must have definitely read that. So my body will utilize all the fat for its energy because fat is one of the stored form of energy. If even the buccal part of fat is consumed, I don't have any other fat in the body. My body is going to go in search of bone marrow fat. So they go and eat the bone marrow fat as well. So when they eat the bone marrow fat, the stroma produces mucin-like material and replaces that. That's what happens here, right? In extreme degrees of starvation, when all the peripheral fat are consumed, that I'm sure you know will be consumed first, the patient becomes extremely emaciated. Then my bone marrow fat is going to be consumed for energy. Normally, bone marrow fat is not used for energy, it's just a support system, that's all. Once it's consumed for energy, it's replaced by a mucinous change. The mucin change happens in the stroma, right? So if this is the pathogenesis, can you tell me the etiology for gelatinous transformation of bone marrow? When can I have this? Or tell me when there'll be an extreme degree of starvation. There's one psychiatric disorder where there can be an extreme degree of starvation, where the patients starve compulsion. Can a patient with an anorexia nervosa have this? Yes, you can, right? So there are few classical etiological factors for your gelatinous transformation of bone marrow. One, it's a finding seen in anorexia nervosa. So I can have a disease, psychiatry and a pathology linked. It's rarely linked, but anorexia nervosa in a biopsy can have this. Second, if a patient is in stage 4 cancer, a cancer cachexia, that will consume all the fat, that will consume all the lean body mass, right? So that could be there as well. Malignancy. Again, malignancy should be in the terminal stage, not in the early stage. When the person is going to become cachectic, the patient might have this, right? Third, the patient is having excess amount of chemotherapy. Sometimes uh, chemotherapy induced gelatinous transformation. My pathogens might be slightly different. They might not have removal of the fat, but stroma will be destroyed. That will kind of give a gelatinous transformation, right? And you can have patients with chronic debilitating diarrhea. They're going to lose entire thing. So again, all the energy is going to divert it, and it's a starvation. My bone marrow fat is going to be completely consumed. Fine. You can have HIV infection. HIV also, HIV tuberculosis combination. Patient becomes extremely emaciated, right? These are all consumption diseases. HIV tuberculosis combination. So these are all causes of your gelatinous transformation of bone marrow. Fine. Now, as I said that, I'm going to have a stromal change where kind of looks like mucin. What happens here is actually there'll be increase in deposition of my glycosaminoglycans, to be specific, hyaluronic acid. The hyaluronic acid gets deposited too much. When the hyaluronic acid deposited, it kind of gives the glassy mucinous appearance, right? Now, I need to prove it is hyaluronic acid there and not just a fat. Right? So how I'm going to prove here is, you must have read about mucin stains, right? Tell me what all mucin stains comes to your mind. You know, normal mucin stains which comes to your mind. Anything? PAS, Alcian blue are mucin stains, right? So if I'm going to ask you which is an acidic stain mucin, which stains acidic mucin predominantly? That's a PYQ, you must have definitely answered it's an Alcian blue, right? Alcian blue doesn't stain neutral mucin, acidic mucin alone. Alcian blue is also positive in case of your mesenchymal tumors, because Alcian blue can stain my hyaluronic acid and the matrix of the stroma, right? So this will be positive for Alcian blue. If you say I'm having an hypocellular bone marrow with the above picture, I'll just go to the picture just for us to imagine. It's not going to be completely fat, it'll be fat with a glistening interstitial matrix. If it is Alcian blue positive, my diagnosis is going to be gelatinous transformation of bone marrow, fine. This is an interesting case. This was a case from a patient with stage 4 cancer. They did the bone marrow biopsy to see whether there's a metastasis to the bone marrow, but unfortunately, we had gelatinous transformation, because this is something which is reversible. It's reversible because if I'm going to make sure I'm going to give good amount of supplementation, the marrow function automatically comes back to normal, unlike the metastasis, which is going to be irreversible, right? As the first case, I hope this is a new case, a new terminology most of us must have learned together. Fine. Let's go to the second case. Again, I want you to comment on whatever comes to your mind. Case 2, I am not going to give you much of history. This is a first image. A first question. Can you tell me what are you seeing here? Like, is it an peripheral smear or is it an FNAC? I'll go with very simple terms. Peripheral smear or FNAC? What do you think this is? It's an FNAC, right? It's not a peripheral smear because RBCs are seen. FNAC can have procedural hemorrhage. There's an FNAC of a thyroid gland, right? There's a thyroid FNAC. Right? So it's a thyroid FNAC. First question for me is this FNAC adequate? You had an INICET PYQ on the adequacy of a thyroid FNAC, right? I'm sure you remember that. Is this FNAC adequate? What is the adequacy criteria? I should have 6 follicles with minimum of 10 follicular epithelials in every follicle, right? Okay. First, yes, You commented no. My only thing is, with this image alone, yes, I would say it's not an adequate, right? I'll tell Satvik. With this image alone, I'll say definitely not adequate, but this is one of the images, right? Here is more, right? Here is more. So considering the entire smear, yes, it might be an adequate definition, right? This is one of the images. So I might call this still adequate, but with that image alone, adequacy is in question, but the entire slide had good enough of thyroid follicular cells, so it's considered adequate, right? Satvik, you had a question of how to differentiate from a supravital stain. Why was that query, first of all? Did you have a confusion of this being your peripheral smear? Is that the reason why you wanted to differentiate from supravital stain? Because it's not a peripheral smear, right? If it is a supravital stain of a peripheral smear, if that is your doubt, in a supravital stain, what do you think will be the color of RBCs? If it's a supravital stain, which is new methylene blue, I suppose you are asking about new methylene blue. My RBCs will be bluish green in color. Right? These are my RBCs. These are not the RBCs, right? The blue ones are not the RBCs, those are the nuclear material. The entire background you can see, which looks more or less your like a rouleau formation, those are the RBCs. That still has the reddish to pinkish color. So this is not a supravital stain, right? There's a GIPSA stain which is done for a thyroid FNAC. Okay, I hope that's settled. So we'll go to a diagnosis. Let's assume that there's a thyroid FNAC which is definitely adequate, right? I'm just going to erase this. So if it's a thyroid FNAC, I told it's adequate. Can you comment on the follicles, what you see here? Do you think there's any abnormality? Actually, few things to look for in a thyroid FNAC. One, I have to look at the background inflammation present or not. Second, I have to look, is there any change in the nuclear morphology, isonucleosis? Third thing, I have to look at the size of follicles, right? I'll enumerate whatever I said. First, obviously for a thyroid FNAC, I have to look for an adequacy. If it's adequate or not, I'm sure you know the adequacy. The same adequacy criteria, whatever you learned in your INICT exam, greater than 6 follicles and 10 cells each. Again, there are lots of caveat for this adequacy criteria. If I can make a diagnosis with 1 follicle, that's enough for me. This is for a negative report. If I'm going to give there's no malignancy report, I need at least this, a minimum number of follicular epithelial cells to report that, fine. Second, I want to look at the size of the follicles. A normal thyroid follicle will be huge. When I say huge, I have follicles which will be like this big. I won't have tiny follicles. I won't have follicles that group very close. The follicular epithelial cell will be bigger because if you've seen a normal biopsy of a thyroid, it's huge. It will be very shape and huge. These type of follicles, I call them a micro follicles. So micro follicles, the notion of micro follicle is it's a thyroid which is not waiting enough to mature and to become functional. That's the reason it becomes very small, micro or an embryonic period of follicle. So if whatever I said is true, can I say if I see lots of micro follicle, can I speculate it's a neoplastic mass rather than a normal growth of thyroid? Because as I said, a normal growth of thyroid will wait for its time to mature. Yes. So this here is a neoplastic mass of a thyroid, right? If it's micro follicles, right? Third, I want you to look at the anisonucleosis. So anisocytosis means variation in the size of the RBCs. Anisonucleosis, variation in the nucleus of the thyroid FNAC. Because anisonucleosis is something which is very characteristic of a neoplastic change seen in the thyroid, right? Next, fourth, and the most important thing, I want you to look for intranuclear inclusions. Okay? Because intranuclear inclusions, if it is seen, even a single intranuclear inclusion is enough for me to make a diagnosis of papillary carcinoma of thyroid. My diagnosis papillary carcinoma of thyroid, it's very classical. I won't see orphan I nuclei in an FNAC because that's a formalin artifact. So I'll see an intranuclear inclusion. An intranuclear inclusion maybe looks like this. There's a nucleus. It's an intranuclear clear inclusion. So I'm just going to have an inclusion in this, maybe like this. It'll be clear. Be like a clearing in the intranuclear part. That's an intranuclear clear inclusion, right? Then I'm going to look for the background. In the background, do I have colloid? Because for colloid goiter, I'm going to look for colloid. Do I have any inflammatory cells? When I have lots of lymphocytes, I can suspect my lymphocytic thyroiditis or your Hashimoto's thyroiditis if there is an antibody presence, or I'm going to look for amyloid. Amyloid will be much more patchy. Okay, it will be much more patchy. Satvik, it's more of intranuclear inclusions, which is diagnostic of an papillary carcinoma thyroid, because it's a pseudo inclusion. So I hope that's what you said as an intracytoplasmic intranuclear inclusion. It's a pseudo inclusion which is seen in FNAC. Right? These are the few things which I want you to look when you pick up an thyroid FNAC. Right? With these in mind, let's go and have a look at these. Can I say, when I look at this, let's go and look at this follicle and this follicle. Can I say it's more of crowded nucleus? It's not a well dispersed follicle. Yes. So can I call them tiny micro follicles? If I can look carefully, it's kind of this. This is a follicle, this is a follicle, kind of overlapping together. Again, here, there's actually a separate follicle, there's actually a separate follicle, right? I'll erase them so that you can easily appreciate them again. They are follicles which are being overlapping very close to each other. Second important point for me here is, again, you have to observe very carefully. If you look at this nuclei alone, does it look a little bit bigger compared to the rest? There's a very subtle anisonucleosis, right? A very subtle anisonucleosis. That's important for me to prove, okay, it could be something of neoplastic origin. I am not saying malignant, of neoplastic origin, right? I'm having microfollicles, I'm having subtle anisonucleosis. Again, these are also microfollicles, right? Very tiny microfollicles, right? When I have microfollicles and little bit of anisonucleosis with no intranuclear inclusions, my first possibility is a follicular neoplasm. I'm going to talk about a follicular neoplasm only. So if you have a follicular neoplasm in mind, how do you report them as per the Bethesda classification? Because all the thyroid FNAC should be reported as per the Bethesda classification only, right? I'm sure you know about Bethesda classification. We'll look at them also soon, right? You'll put them as category 3, category 4, or category 5 or 6. There's a follicular neoplasm or suspicious of a follicular neoplasm. Everything is reported as per Bethesda. Okay, your question is, how is malignancy different from neoplastic invasion? Malignancy is the property of the tumor to exhibit invasion, right? So it's not going and targeting the same thing. That's the only thing I would want to say. I don't understand your question. First of all, malignancy is a tumor which has the capacity to invade. That's what I call them a malignant neoplasm. Invasion is a property of malignancy, right? That's what invasion means. And malignancy is any tumor which can spread, metastasize, or invade. I'm going to call it a malignant. Right? Fine. Let's have a look at Bethesda classification first. Okay, yes is commented 3. Bethesda classification 3 will be follicular neoplasm or ATP of undetermined significance. It's generally ATP of undetermined significance, right? It doesn't come under follicular neoplasm, it will come under your ATP of undetermined significance. Now, if you look at the Bethesda classification, what I'm going to have is the first one, the category 1 of Bethesda. That's where my non-diagnostic FNAC comes, like a non-adequate. I have only one follicular epithelial cell in the entire smear. I'm not able to pick it up at all, right? So one is going to be non-diagnostic. I'll tell you the criteria as per Bethesda. I'm putting a star there because when you do a non-diagnostic FNAC, which means I've poked into a thyroid and I have not got any material. Either it's only fluid or I'm not having anything, completely hemorrhaging. I'm not able to diagnose at all. So can I say, if I poke a needle into a thyroid, will it cause an injury to the thyroid? It will. If it's going to cause injury to the thyroid, am I right in saying that I should wait for it to heal and then only I should repeat the FNAC? Yes. That's one of the important problems of an FNAC. I have to get a good FNAC as the first point. I should not be a bit relaxed, or I should be technically competent to do an FNAC, because once a non-diagnostic FNAC comes, as per the criteria, though it's not routinely followed, I should wait for at least minimum of 2 weeks to repeat FNAC. This, as I said, this generally is not the criteria. They do the same next day itself, but again, there's more chance of having an unwanted diagnosis when I repeat immediately. I should wait at least for 2 weeks to repeat an FNAC if it's non-diagnostic, which means you have to train yourselves for an FNAC. FNAC are generally done by pathologists. Surgeons can also do an FNAC. Generally, it goes to the pathologist because of these discrepancies. If I'm going to do, I'll be more cautious enough to take good amount of material. If it doesn't come, I have to give a negative report, right? That's where your non-diagnostic comes. That's Bethesda category 1. Bethesda category 2 is where most of the benign conditions comes. My report will say it's Bethesda category 2, that's all. I can say it is a colloid nodule or an adenomatoid nodule or Hashimoto's thyroiditis, lymphocytic thyroiditis. I can give the subdivision. If I'm not able to give the subdivision, I can just say Bethesda category 2 benign thyroid nodule. That's more than enough. If I want to complete it, I should give C bar W is consistent with, and let's say adenomatoid nodule or an colloid nodule. I should say consistent with Hashimoto's or an lymphocytic thyroiditis. Again, I'll call it an Hashimoto if there's a clinical information of your serology available, or I can use the term granulomatous thyroiditis. That also will come under you, Bethesda category 2 only. Fine. Okay. 3. Bethesda category 3 is what most of the surgeons hate. Right? They hate Bethesda category 3 because I'll give them as ATP of undetermined significance, which means in real life, I'm not sure what I'm seeing. Right? It's a very cautious report just to make sure my head is safe. It's ATP of undetermined significance, undetermined or an uncertain significance, whatever it can be. Right? It's ATP. I don't know what it is exactly happening. ATP of an uncertain or an undetermined significance, right? Which means here, ideally, the way of the follow-up of your Bethesda category 3 is, if the surgeon feels that this patient clinically might be malignant, like an age or some other evidence, surgeon goes for surgery straight away. The surgeon feels strongly the patient is still normal, repeat an FNAC after 6 weeks. I have to do that. That's how the protocol says, right? The Bethesda category 4 is where our case, what we saw, will come under. It comes under follicular lesion. It can be follicular neoplasm or suspicious of follicular neoplasm, or if I'm more comfortable, I can also give Hürthle cell type neoplasm. Fine. It'll be, I'm writing FN for follicular neoplasm, or it will be suspicious of follicular neoplasm, or I can even comment on the type, Hürthle cell type, because there are Hürthle cell type follicular adenomas, Hürthle cell type follicular carcinomas as well. It's a follicular neoplasm. The variant special type is Hürthle cell type, right? Where do you normally see Hürthle cells? Normally, where do you see Hürthle cells? Where do you see Hürthle cells normally? Hürthle cells are normally seen in Hashimoto's thyroiditis, right? So Hürthle cells are normally seen in Hashimoto's thyroiditis. So Hürthle cell is a cell with abundant amount of pink color cytoplasm in a biopsy. And just going back to my case, this is our case. When you look at this cell, can I say, assume this cell, compare this cell to the cell here. I'll mark them 1 and 2. Compared to the second marked cell, the first cell, do they have good amount of cytoplasm? The entire cluster. Do they have good amount of cytoplasm? They do have good amount of cytoplasm, right? So this is how an Hürthle cell will look on an FNAC. It will be a little bit more cytoplasm, more amount of cytoplasm will be there, which is not normally the case of a thyroid follicular cells, right? So in a JIPMER stain, it will not be pink in color. It will not be pink in color. In a JIPMER stain, the cytoplasm will be bluish only, because JIPMER doesn't have pink and blue. It has shades of blue. That's all. Dark blue for the nucleus, light blue for the cytoplasm, right? So don't compare whatever we read in your biopsy for this. This will not be a perfect match, fine. So this could be a follicular neoplasm of a Hürthle cell variant. I didn't report them as a Hürthle cell variant because for me on an FNAC, the variant diagnosis is not must. My goal of FNAC is I should not miss a malignancy. I should not call a benign malignant. I should not call a lymphocytic thyroid something else. That's more than enough. If you are extremely good in FNAC, you can go for the variant. But for me, follicular neoplasm is good enough. Even if I say variant or neoplasm, the surgeon is going to remove the thyroid gland, obviously, right? Okay. So fine. But this category 5 will be suspicious for malignancies. It will be suspicious for any other malignancy, which means papillary, medullary, metastatic, or lymphoma, right? It's suspicious. Again, it's not cancer, proven cancer. It's suspicious of papillary, suspicious of medullary, could be suspicious of lymphoma as well. Right? Except for follicular, because follicular carcinoma, I cannot pick up on a FNAC. That's a very, very famous MCQ, right? Etc. category 6, it's frankly malignant. I can diagnose it's malignant either again PTC or an medullary carcinoma thyroid or a lymphoma. If it's frankly malignant, I'm going to give them, fine. So these are the 6 categories of Bethesda. Okay. So the thing here is the category number 4. Category number 4 is where most of the MCQs are concentrated on, because that's kind of a link between a pathology and a surgery. That's where your FNAC cannot diagnose follicular neoplasm comes. And what is the next step if the report says the solitary thyroid nodule, which is a follicular neoplasm, fine. There are a few things which I want to take care about your category 4 alone. If I'm going to report something as category 4, I'm coming to that, Satvik. Just give me some second. As I report category 4, I can say follicular neoplasm, right? What we read that it is not useful to differentiate whether it's follicular carcinoma or an adenoma, right? Because category 4 suggests it's follicular neoplasm. Like you said, neoplasm term encompasses both benign and malignant, right? So I cannot differentiate. To differentiate from follicular adenoma versus a carcinoma, it's impossible on an FNAC because, like you said, I need capsular and vascular invasion. But I can say follicular neoplasm. If I report follicular neoplasm, then it's left to the surgeon to do the surgery. The surgeon will either do one hemithyroidectomy or a total thyroidectomy based on the size, location, age, everything. That I'm going to leave to the surgeon. The surgeon will do the surgery. Post-operatively, post-surgery, histopathological examination, I'm going to look at the microscopy. Now in microscopy, if you have an adenoma, there'll be no invasion. There's no invasion of capsule or my vascular. I'm going to call it an adenoma. Both. Nothing should be there, right? If there is any invasion of either capsule or an vascular invasion, I'm going to call it a follicular carcinoma, right? Okay. Something, the reason for doing an FNAC is to have an presumptive diagnosis. It's a follicular lesion. If it's papillary carcinoma, I can easily pick it up. Only follicular has a problem. That's why I'm going to still go and do it the FNAC for every solitary thyroid nodule and see what I'm going to do. This we already know. What I wanted to convey to you is, for every future surgeons watching here, there's a little bit of a miscommunication from the pathology department and the surgery department. I want to bridge the gap so that in future when you become a surgeon, you will know the limitations of a pathology, limitations of frozen section. So what happens here is, most of them, if it's a cat on a wall situation, like if I cannot clear-cut differentiate whether to go with a total thyroidectomy or hemithyroidectomy, clinically, they do a thyroidectomy, hemi, or just they remove the lobe, and they ask for a frozen section. Because I'm sure you must have read that frozen section can differentiate benign from malignant, right? Yes, Satvik, confirmation is always post-surgical histopathological examination, right? You must have read for sure frozen section can differentiate benign and malignant. But I have a big trouble here regarding frozen section for follicular neoplasm. I'll tell you the trouble. If it is logical enough, next time don't send frozen section, because I cannot give a perfect report. Let's assume you are removing let's say a part lobe of a thyroid where I had a perfectly round solitary thyroid nodule, right? If it is it's a round thing, it's a three-dimensional structure, right? And I'm going to have a three-dimensional nodule like this. In a frozen section, I can have only one biopsy, only one slide, or maximum two slides. But if I have a nodule like this, I have to cut at every 1 centimeter throughout. Right? If it's like this, I have to cut at every 1 centimeter. I should cut throughout. That is not possible in a frozen section. So which means even if I do a frozen section, let's say I can maximum do 2 bits. In 2 bits, I can see invasion present or absent. That's all I can do. So if say this big is a tumor, I have cut here and I have cut here, 2 bits I have seen here. So in these 2 bits, I will say present or absent. But I can never be sure what happens in these areas, right? I can never be sure. And it's impossible for me to slice the entire tumor in a frozen section, because in frozen section, my architecture will not look good. I need fixation for that, right? So now also coming back, even with the help of frozen section, if I don't see an invasion in the 2 bits, can I 100% say it is follicular adenoma, or will I not be able to comment on that? I will not be able to comment on that, right? So even in frozen section, it's still a problem. I cannot comment whether it's an adenoma or a carcinoma. So post surgery, once you remove the entire thing, the way to cross a follicular lesion is very, very important. If let's say it's an 5 centimeter lesion, I have to cut this every 1 centimeter into 5 or 6 slices, and then I have to paint the entire capsule and look for invasion. For a single solitary thyroid nodule, that'll be easily 15-20 slides. I have to look at every nook and corner to comment on invasion. That's possible only post surgical. It's not possible on an FNAC. It's not possible on a frozen section also. Fine. It's after fixation. I'm going to do that. That's the reason I wanted to convey this. Hopefully, if you become surgeons in future, don't ask for frozen section. I'll give a half-baked report. Okay. That's about the second thing. Third, since we're in frozen section, I am going to give you an frozen section which came to the lab. Let's see if you can pick it up. It's a kidney mass. Let's see if we can pick it up. Comment on the kidney mass. It's a frozen section. This is how a frozen section looks. I am sure you'll accept that the architecture is not good, right? So tell me whatever comes to your mind. I'll come to this. I'll come to it. After this, I'll take your query on margin positivity in frozen. I'll come to it. Comment on whatever comes to your mind. Anything? Okay, at least the color. As I said, it's a renal mass. The color should be visible easily, right? Pink, blue, or clear. It's at least predominantly for me pink in color, right? I'll go to one more image if you can pick it up. There's a second image. Tell me what comes to your mind. If you want, I'll zoom it up. It's actually a very classical case. I thought you guys will pick it up. It's pink in color. Yes. Oncocitoma. Great. Does it look like an oncocitoma? Do you guys accept with Satwik's diagnosis? Angiomyolipoma. Okay, I'll take that as well, osmosis. Why did you comment on angiomyolipoma? But this part is not this part is not lipid, right? It's just the background material. It's not properly fixed, so it looks like that. It's not an adipose tissue. If you have thought that's an adipose tissue, right? That's not an adipose tissue, right? And I do not see your muscle fragments also here, right? Most of the time there are loose stromal material, and I see gland-like appearance here, right? So this was reported as a case of an oncocytoma. Fine. First question: why did they take a biopsy here? Why did they ask for a frozen section here? Or in other words, what's a very close differential diagnosis of oncocytoma? is a very, very close differential diagnosis of an oncocitoma, which is chromophobe RCC, right? So if I will not be able to, okay, I'll come to that. Yes, if I'm not able to differentiate oncocytoma from a chromophobe RCC radiologically, they ask for a frozen section. Because in frozen section, I can easily pick up a chromophobe RCC from an oncocytoma. I'll tell you how both of them looks and why this is an oncocytoma. Fine. First thing, okay, first I'll come to your plant cell. I'll take your other question of how to see margin frozen section, and then I'll look at the oncocytoma and chromophobe RCC difference. The plant cell appearance is not the foremost thing which is important for me for diagnosis. That might be present, might not be present, right? It's more of an overhyped structure, overhyped thing. There are two things which I rely on a microscopy to differentiate chromophobe RCC from an oncocytoma. One, chromophobe RCC will have a perinuclear halo. That is very, very classical. And chromophobe is an RCC. It's a cancer. So can I say there'll be nuclear variation in the nuclear size shape? That will be there, right? So the main difference between a chromophobe RCC versus an oncocytoma, because both of them clinically, radiologically, they'll be well-defined neoplasm, fine? Since they are well-defined neoplasm, it will be a bit difficult for me to pick up on radiological imaging that they are benign or malignant. That's one problem for me. And since both of them arise from the same origin, the intercalated cells, it will be a bit difficult. Again, radiologically, based on the location, I will not be able to differentiate, fine? Both of them might have a central scar. So radiologically, it's a bit difficult, though there are few tests to differentiate, and definitely a radiologist who is experienced in the genitourinary system can easily differentiate. But still, there might be subtle differential diagnosis. When it comes to microscopy, chromophobe RCC will have a perinuclear halo. That's a very characteristic feature of chromophobe RCC. Oncocytoma will be completely pink. It will have a complete pink cytoplasm. It will not have a halo. And oncocytoma, on the other hand, will have perfectly normal nuclei. There will be no pleomorphism, nothing. Here, I'll have hyperchromasia. That's what the raynaud appearance is. It will be hyperchromatic because obviously it's an neoplasm. It's a cancer, right? I can have increase in the nuclear size and variation in the nuclear size as well, right? So these both are going to help me to differentiate the chromophobe RCC versus your oncocytoma, fine? If this is my nucleus, I don't have a pink color, so I'm using the other colors. So I'll have an halo surrounding them, fine? If you have an halo surrounding the nucleus, I'm going to call it a chromophobe RCC. Okay? That's a very, very classical finding. Now let's go back to this image and see. These are my nucleus. Am I seeing any halo here? Is there any halo surrounding the nuclei? We don't see any halo, right? Now tell me, what are these? Is this a halo? This clear area, is that a halo? Is that a halo or not? That's not a halo. What is that? This part is a lumen, right? It's a tubules lumen. You can see the tubules lumen here as well. You can see the tubules lumen here as well. It's not perfect. It's not perfect because that's the disadvantage of a non-fixed frozen section. Frozen section will not give me a perfect morphology. That's why I'm having all these troubles, but still I should be able to differentiate with good amount of certainty. You can easily diagnose and differentiate between these two, right? Now let's look at the other use of frozen section. Like you guys must have read, there are different use of frozen section, and yes, also asked how to identify a margin positivity in a frozen section, right? Because this might be very, very important for a practicing surgeon more than undergraduate. So I'm sure if you're going to become a practicing surgeon in future, this might be of help for you, right? So let's take, you're doing a breast conservative surgery. There are only two rules of frozen section. One is for margins, second sentinel node biopsy, and like whatever we saw to differentiate from benign and malignant, like your oncocytoma was your chromophobe RCC, right? So in breast conservative surgery, I can do for two things. One is sentinel node groups, other one is your margin positivity. There are few important things for a sentinel node groups to identify. What I'm going to say is a protocols what we follow. This is laid by College of American Pathologists. This is a perfect protocol. There might be subtle variations in few institutions, but we follow the same protocol. First, how do you identify sentinel group of lymph nodes? Intraoperatively, I'm sure the surgeon must have taught you this. How do you pick up sentinel group of lymph nodes intraoperatively? So I'm sure you know there are two ways. One, a rich one, other is a poor one, and mostly India does a poor part. Either I use an visible ink, a blue color methylene blue dye, and I take the first group of lymph nodes, which becomes blue in color. That's the first thing. I inject the dye in and around the tumor, and I look for the change in color. Second, I can do a radio tracer dye and use a gamma camera. Fine. So if a surgeon has used an blue color dye and visibly some lymph nodes are turning blue in color, they take the entire thing. Right? Take the entire thing and give it to me. I should isolate 4 lymph nodes in that group. It's not a single lymph node. I don't look for a single lymph node. If I get only one lymph node, it is considered the sentinel node dissection is incomplete and you have to go for a complete removal of the axillary node. Only if I see 4 lymph nodes, and if all the 4 lymph nodes are negative for malignancy, which means sentinel group of lymph nodes is not involved, you can avoid the axillary node dissection. It's not one lymph node. In general, what you must have read as an undergraduate is, okay, first lymph node not involved, 3. It's not first lymph node, it's the first group of lymph nodes, and that should be minimum 4 lymph nodes. So what happens is, initially when the surgeon gives us a lymph node, a chunk of tissue, and if I'm seeing only 2 lymph nodes there, I will report 2 lymph nodes free of tumor. The surgeon will look for the same blue color discoloration in the next group of lymph nodes and take 2 more. I should have 4, which is negative. Once it is negative, there is no need for axillary node dissection. Okay. It's not 1, it's a group of lymph nodes 4. That's first use in breast conservative surgery. The second use is for margins. Let's assume you have a 2 centimeter tumor. Breast conservative surgery, I will not leave enough margins, right? So what I will do is, let's assume there's a breast conservative surgery has come and we have cut that. Once you have sliced, let's assume this is the tumor. I'll mark an irregular red thing for a tumor. So first, grossly, I will measure the length. Let's say the length between the tumor to this margin, and that margin will be sutured by the surgeon. Okay, 1 knot for anterior margin, 2 knots for lateral, 2 knots for superior. Like that, we'll have markings so that I know which is superior, which is medial, which is lateral. All the 6 margins for a breast conservative surgery. Then measure them grossly. If grossly the margin is more than 2 centimeter, I don't take that for section, because as I said, in frozen section I'm not going to waste everything. If grossly is more than 2 centimeter, we ignore that margin. We consider it is free. But let's say this margin appears closed, right? So this I take a section. When I say section, I remove the chunk of tumor along with the margin. So we'll cut this part totally, right? We cut this entire part totally, and then we look them into the microscopy. So this is how the part will be in microscopy here, and I'm going to have a tumor here, and the corner will be stained with ink. We have different color inks. Ideally, a pathology lab should have 6 color inks for 6 margins, but generally we use black. Black is one under microscope might not disappear. Other things like blue or yellow might disappear. It will be a bit difficult. We use 1, that should be more than enough. And when I say that, let's assume this is lateral margin, and this slide will be mentioned as lateral margin. And this slide, I'm going to do the same thing here, top, and I have a tumor, and this slide will be mentioned as, let's say, superior margin, just for an example. Now what I do in microscopy is, I'll have to look in the microscopy the extent of tumor cells. If it's in microscopy, this is how the tumor goes. This is how the tumor goes inside, and this is where I have the margin. This is how the tumor goes all throughout. I have to measure this length. That's what is the tumor-free margin. It can be as small as 1 millimeter. If I have a tumor cell in this margin, it's considered incomplete resection. You have to remove 1 more. If the margin is free of tumor, the surgeon sometimes might extend the cancer surgery, or sometimes he'll leave just like that, because if he's confident that will not recur. Based on the patient protocol, they might leave or they might resect more. But if I have a tumor cell at the ink margin, definitely you should resect the tumor again. Fine. So this is how we checked for the margin stages for any surgery, be it breast conservative, again example. I can do this for gastric surgeries, colonic surgeries, any surgery for the matter. Same way, we're going to look for margin status, fine. That's when, if it's on the margin, we call it positive for the tumor. If it's not in the margin, we are going to call it negative for the tumor. I hope it's clear, yes? Okay. We'll go to the next, one more case, the fourth case. See if we can pick up and come to a diagnosis. Okay. First, tell me, what biopsy is that? This is an old case which came to me when I was studying my post-graduation. It's a very good case as well. I'll never forget this case. What biopsy is this? You can give me a broad thing, that's more than enough for me. Is it intestine? Is it stomach? It is what it is. What biopsy do you think it is? Anything which comes to your mind? Intestine. Okay. So if it is in intestine, I'm going to ask you a few more leading questions. Do you think it is small intestine or a large intestine? If it is small intestine, comment on whether it's duodenum, jejunum, or ileum. Glands plus villi, right? Amazing. That's a very good catch. You do have villi, right? Can you guys appreciate the villi? So here it's a bit broken. I hope you'll be able to appreciate the villi, right? I'm having glands plus villi. Vesivilli, and it's not just the glands. There is one more important thing here. What are these? What is the one which you have circled? Does it ring a bell? That's how a Brenner's gland look. It's light color. That's how Brenner's gland look. If it is Brenner's gland, what biopsy is this? Brenner's gland is a MCQ for you. Where do you see Brenner's gland? You see them in duodenal biopsies, right? This is a duodenal biopsy. Now let's look at the duodenal biopsy. It's a low power image. Does it ring a bell? Anything you can comment on this duodenal biopsy? If nothing, I'll go to the higher power. Higher power will easily give you the diagnosis, but still, I want you to try it on a lower power. Okay, let's go to the higher power. Diagnose. So you'll diagnose that. What do you think is the diagnosis? It's giardia, right? It's a classical case of a giardia. As I said, it's not a difficult thing for you guys. I'm sure you'll come to an easy diagnosis, right? It's a classical case of giardia. If you can look, there are few things. There's no granuloma here. These are my organisms here. Yeah, actually, this is a very good image. Can you see the pear-shaped structure, like what you read in your microbiology textbook? It's very rare to pick up the pear-shaped structure here, right? Generally, giardia will be like this, The pear-shaped structure are rarely seen, right? The pear-shaped organism and all this are a bit rare. Flagella will not be picked up on a biopsy. Don't look for flagella. It's just like an elongated tail. If you have like that, it's giardia, fine. One thing which I want you to look carefully in giardia is this here is a villi, right? In the villi, do you have any inflammatory cells? Are you seeing any dense inflammation or not? Because I'm having a parasite here. Ideally, I should have lots of inflammation whenever I have anything, right? Any parasite for the matter. I'm seeing anything here? No, right? The reason why I'm not seeing any dense inflammation in that part is giardia is an invasive organ or an organism or a non-invasive organism. Giardia is completely a non-invasive organism, right? Giardia is non-invasive. It will secrete kind of a toxin which will disrupt the crypt's epithelium that causes an malabsorption diarrhea. Since not invading, I will have very little stromal reaction. There'll be very little inflammatory reaction in this condition. That's one thing to appreciate here, right? So can you guys, there's one more finding here. Can you guys pick them up? There's one more finding in this villi. Can you guys pick them up? There's one more classical finding here. Anything which comes to your mind? Anything? Okay, what do you think these are? What do you think these are? This, 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 and this. Yeah, a multiple of them. What are those indentations in the epithelium? Foam cells. Okay, this is an intestinal, this is a small intestine, duodenum. So will that be foam cell, or can I call them a goblet cell? They do look like goblet cells, right? So can I say that this duodenal epithelium, there's a low power image. In the low power image, actually it's much more appreciable. Can I say this duodenal epithelium has good amount of intestinal metaplasia? They do, right? There's a good amount of intestinal metaplasia. That's, though it's not a very important finding, I want you to pick the subtle findings so that in an exam your eyes becomes more trained. That's all, right? There's a good amount of intestinal metaplasia. Along with that, there's GRD as well. Right? They are goblet cells. Yeah. Right. For the next case, this is not from my case. This is from textbook. I just want you to comment on the diagnosis. This is a spotter. Just comment on whatever comes to your mind. Anything comes to your mind? No. There's a spotter. This is from a bone marrow aspirate. This is a very classical spotter. This is a blast. I just want you to comment what type of blast it is. This is not a multiple myeloma. Anything else? It's a very classical blast. These are not plasma cells. No. Okay, I thought you guys must have seen this. Fine. Let's have a quick look about that. But this is not a multiple myeloma. This is a classical case of Burkitt's, right? This is Burkitt's blast. The classical case of Burkitt's blast. Do not miss them, right? Yeah, L3 blast, which is the other name for Burkitt's blast, right? L1, L2, L3 were older classifications, though I don't use them with comfort these days. But yes, this is an L3 blast, which is in Burkitt's blast, right? L3 blast has two important things. One, they have a little bit of blue cytoplasm. Second one, they have vacuolations in the cytoplasm. Okay. If you remember, we did read about the different types of blast of AML yesterday when we saw two cases of AML M4 with eosinophilia and M6. So which of the AML or myeloid blast will have blue color cytoplasm? We saw the difference. No, Vijay, this is not a case of multiple myeloma. It's a case of Burkitt's blast. Which will have blue color cytoplasm? Erythroid blast, AML M6 blast also have blue color cytoplasm, but they don't have a vacuolation, right? So if you remember, we have few special stains for diagnose for different types of blast, right? I'm just going to give a reason for those special stains so that again, my only purpose is once you read them, you should not forget them, fine? Going up here, the first thing I'll take is PAS. In which blast do you think PAS is positive? In which of the blasts PAS will be positive? Erythroid, myeloid, lymphoid, which blast PAS will be positive? PAS will be positive in many blasts. The first thing, I'll take lymphoblasts. In a normal lymphoblast, which is L1 and L2 type only, PAs will be positive. In L3, PAs will not be positive. I'll give you a reason for that as well. In a lymphoblast, can I say, in general, a lymphocyte as an inactive cell? I'll tell osmosis. Lymphocyte is a very, very inactive cell, right? So when lymphocyte is an inactive cell, yeah, it'll have a dot-like positivity here. The reason for the dot-like positivity is when I have a lymphoblast, I'm going to have a very inactive nuclei. That's why it has a dark chromatin. It's a heterochromatin. But if it's an heterochromatin, it is going to store all my glycogen, which it might use on a later date. The glycogen will be stored in the form of tiny vacuole here. That will become positive for my PAS because glycogen will be positive by PAS, right? That's why I'll have a dot-like positivity, maybe more than one dots. In general, mostly one dot, right? Now let's take at your other blast. Okay, M6 will have blush-like positivity. M3 is generally your MTO positive. They are not PAS positive, right? When I take M6, AML M6, which is erythroid blast, can I say the earliest stage where a hemoglobin will be formed in an erythroid is your proerythroblast? In my proerythroblast stage itself, I'll have lots of hemoglobin formation, right? So whatever blast I take in my M6, I will have in the cytoplasm hemoglobin. In this hemoglobin, the globin component is the protein. If you remember PAS positivity, did you read that PAS will be positive in case of alpha-1 antitrypsin deficiency? It will be positive in case of alpha-1 antitrypsin deficiency, right? So if that is positive there, it will highlight protein as well. So when I do PAS for an erythroid blast, it will have a cytoplasmic blush-like positivity circumferentially, right? You'll have a blush-like positivity toward the circumference of a cytoplasm. This is because of the hemoglobin and the globin part of the hemoglobin, which is a protein, which also will be stained by PAS, but it's not a dot, it will be uniform throughout, right? Third one for me is AML M7. The M7, what we saw yesterday was M7 will have a very high NC ratio and they'll have blebs in the cytoplasm. It will not be uniform, they'll have blebs in the cytoplasm. That's one of the clues for my M7 blast. M7 is megakaryocyte. You must have definitely read this. Platelets are formed by pinching off of the megakaryocytes, right? That's how platelets are formed. If that is true, can I say the cytoplasm of the megakaryoblast will have the raw materials required for platelet formation? And the raw materials required for platelet formation, I'm sure you know this as well. Every platelet in my body will have glycoprotein 1b9 and 2b3a. Yes. So here, this cytoplasm will be abundantly rich with glycoprotein 1b9 and my 2b3a. It will be scattered, it will be dots like, right? Again, it's a protein. Protein will be positive for PAs, like the same hemoglobin. It's a glycoprotein, it will be positive, right? So when I take a megakaryoblast, it will be positive like this. It will be granular positive, it will be diffusely positive, right? If it's granular and diffuse, I'm going to talk about an M3 blast. If it's circumferential and like a blush, I'm going to think of an erythroid blast. If it's dot-like positive for a PAs, I'm going to think of an L1 and L2 blast. The fourth one is my Burkitt's blast. Now let's look at Burkitt's or my L3 blast. The only difference between my L1, L2 and L3 blast is the nature of the tumor. What do you think is a Ki67 for a Burkitt's lymphoma? Low, high? What will be the Ki67 for a Burkitt's lymphoma? Ki67 is 100%, right? So can I say a Burkitt's lymphoma, though it's a lymphoid tumor, lymphoid blast, it will always keep on multiplying. It will multiply, divide, it goes into next cell cycle, divides, it goes into next cell cycle, divides. It keeps on dividing. So can I say the stored glycogen will be utilized for my cell cycle? It will be utilized, right? Because it's constantly dividing, I need energy, and my storage form of energy here is glycogen, I'll utilize it. Once I utilize it, though Burkitt's being a lymphoid blast, will they be PAs positive or negative? They'll be negative for PAs. It will not be positive for PAs, right? They have to be negative for PAs, right? At the same time, when you look at the microscopy of the Burkitt's blast, I am seeing vacuoles. Vacuoles are clear. Anything clear in my biopsy microscopy is going to be composed of fat. If it is fat rich, as Satwik said, it will be oil redo positive. Can you guys name any other marker other than oil redo for fat? That will be positive here. Oil redo will be positive, but I don't want to go there. I want to go for the other marker, which is SBB. Then the SBB positive. This is very unique for Burkitt's blast. Why it is unique is, in general, which blast would be positive for SBB? Lymphoid or myeloid? In general, it will be myeloid blast, right? Generally, myeloid blasts are positive for MPO and Sudan black B. Lymphoid blasts are positive for PAS. That's how it is, right? But here it's actually the reverse. It's a lymphoid blast which is negative for PAS and it's positive for SBB, right? That's unique, and anything which is unique and different from the routine, it might end up in an MCQ. So do remember them without fail, right? Okay. Yes. Okay, this is spotter again. Just going to show the image and only one word regarding that. Let's see if we can pick it up. Diagnosis, it's a bone biopsy. You should be able to pick it up. Diagnosis. A very, very simple case. Any guesses? Fish hook blood vessels. Okay, if it is, I said I gave you a clue. It's a biopsy from a bone. And those are not blood vessels. I'll give you one more clue. Whatever you're seeing here are bone trabeculae. Now, do you want to change your diagnosis? I said it's a spotter. You should definitely pick it up. And you will pick it up. You give up? Okay. Does it look like Chinese letters? Look at this part. Do they look like Chinese letters? Can I call this Chinese letter pattern appearance? It does look like Chinese letter type, right? Don't give up osmosis. You know the answer. Diagnosis? It exactly looks like a Chinese letter appearance. So what will be a diagnosis? It's a classical case of fibrous dysplasia, right? The Chinese letter appearance is classically seen in case of fibrous dysplasia. It's a good case. It is a classical spot of fibrous dysplasia, right? Fibrous dysplasia is a malignant disorder or it's a developmental anomaly. You must have read about fibrous dysplasia. It's malignancy or developmental abnormality. It's fine. Now you know. So anything in future it comes regarding fibrous dysplasia, I hope you'll not miss it. Right? It's malignancy or developmental anomaly. It's definitely an developmental anomaly, right? But still, I have the word dysplasia there because dysplasia is an abnormal growth and it's not supposed to be used for anything which is not malignant or cancerous, right? So why the word dysplasia came is, let's look at zoom into the Chinese letter trabeculae and have a look. This is the zoomed image of the same trabeculae. Tell me what is abnormal in this trabeculae. There's something which is strikingly abnormal in this trabeculae, and that's the reason I'm going to call it a dysplasia. In spite, there is no malignant component here. What do you think is drastically abnormal in this trabeculae? Okay, I gave enough time. So let's see. Can I say a normal trabeculae should have osteoblasts lining the trabeculae? Normally, what happens is, let's say this is kind of an osteoclast like a reaction. This one here is an osteocyte. That's how an osteocyte looks. Maybe this is an pit where you can have the osteoclast. Actually, I should have osteoblasts here. The normal bony trabeculae, I should have osteoblasts lining my osteoid rim. That's how it should be normal, right? Yeah, fibers is fine. That's why I'm using the term fibrous. There is no osteoblasts here. There are no osteoblasts lining the trabeculae. That's a very, very important finding for me. Because when I don't have osteoblasts lining a trabeculae, my first possibility is malignant osteoid and osteosarcoma. That's what we think of anywhere when I see an osteoid without a trabeculae, when I see an trabeculae without an osteoblastic lining, right? There is no osteoblast here, but still it's not considered malignant. It's a developmental anomaly. That's a term why we use. It's in fibrous dysplasia, and I don't call it anything else, right? This is something abnormal which is not seen in a non-malignant bone. That's why we use the term dysplasia, right? Okay. Okay, this is a very simple question. So we have two things which might be a little bit on higher end, your fibrous dysplasia and the Burgess blast. Let's come to this question. It's a patient, let's say 40-year-old person, who came to the OPD for some finding and a peripheral smear was done. The low power image, comment on it. I'll give you clues where to look for. In a peripheral smear and a low power image, you cannot look at the morphology. You can only look at the number. So tell me whether I'm having good amount of RBC, WBC and platelets. Most welcome, Vijay. The only thing which I can comment on this power is the number. Can you comment on that? Do you have good amount of RBC, WBC and platelets, elevated or reduced? So can I say definitely this patient has leukocytosis? It's good amount of increase in the WBC, right? It's too many. It's too many for comfort, right? Though I cannot see the platelets here, one thing you can say is there's definitely leukocytosis, right? So if it is leukocytosis, let's go to the higher power and see what they are made of. There's an image. The comment on the WBC subtypes. Are they normal, abnormal? Do you want to comment anything? Here I can see the morphology. So I can comment on the lineage. Which lineage is more? Is it neutrophil? Is it lymphocyte? Is it eosinophil? Or if I'm having any immature cells as well. Pelger anomaly. Okay. I'll take it. I'll take it. But I have a different finding for that. We'll see. Much cells. Ignore these. It's artifact. Band forms. Okay. There are two comments on few of them. One of you have commented as a Pelker anomaly. One of you have commented as band form. Right. So let's see what's correct. Again, one more image. Do you see anything else in this finding? This diagnosis you have already read, you must have already known. I just want you to apply whatever you read. What is this? What is that? That's a classical finding, isn't it? What is that? If you can pick up, I'll help you to arrive to a diagnosis and discuss based on that. Okay, whatever cell I have marked, it's an immature cell or a mature cell. Comment on whatever comes to your mind. You might be wrong, that's completely fine. Can I say it's an immature cell? It's undoubtedly an immature cell, right? It's an immature cell, perfect. So it looks like a blast, right? Okay, now let's comment on few other cells in the same field. This cell, this particular cell, does it look like a mature neutrophil or does it look like a band form? I'll come to it, Satvik. Too much of granules. Great. That's a good finding. I'll keep that also. That cell which I've circled looks like a band form or an immature or a mature neutrophil. It's a band form, right? Great. Okay. Osmosis, you commented on this image. I think you have Pelger-Huey anomaly, right? If it's a Pelger-Huey anomaly, they should have less number of granules or more number of granules. They should have less number of granules, right? They're hypogranulated and hypolobated neutrophil. That's a Pelger-Huey anomaly. But when you looked at a bit higher power, you only commented that I am having more amount of granules. So it's not a Pelger-Huey anomaly. It's just a neutrophilic band forms, right? So the easiest way to differentiate is the amount of granules. So granules is sufficient. It's not an anomaly. It's completely fine. Okay, great. Now I'm going to tabulate whatever findings you said. Maybe I'll put it in a proper line. Let's see if we can come to a conclusion. Can I call this smear a patient with leukocytosis and shift to left because I'm having immature band forms, bit of let's say it kind of looks like a metamyelocyte or tomyelocyte, and have promyelocyte to a blast as well. Can I call this shift to left? If you have an elderly person with neutrophilic left shift and leukocytosis, what are your differential diagnoses? There are two differential diagnoses which should come to our mind for an undergrad. What are they? Neutrophilic shift to left with leukocytosis. The differential diagnosis, what are they? Perfect. One is CML, the other one, you must have heard about something called as an leukemoid reaction. It's a very common MCQ point, right? I have two things. MDS will not come to my mind when I have neutrophilic shift to left and leukocytosis. I have to think of leukemoid reaction versus CML. These are the important differential diagnoses for the above this case at least. So I have either it should be a CML, or you must have heard about this reaction, right? Leukemoid reaction, which is leukemia-like reaction, which is reactive. Fine, great. So points to favor CML in the smear, and I have to look for that. What will you look for? If these are my two differential diagnoses, I have to revisit my smear and I have to look for few characteristic findings which is suggestive of CML. What is that? There's one cell which will be elevated very, very classically in CML. What cell is that? I'll come to Chatwik. I don't want lab score. We'll go with more of an information which you already have. Lab score is there. I'll come to it later on. I want something in the smear which, if I see, I will push the diagnosis more towards CML. Is it more monocytes or is it more basophils? More basophils, right? Perfect. So are you seeing basophils? I have an image here. I have a high power image here. There are easily some 30-40 cells. Easily. Are you seeing more basophils? Yes or no? I don't have basophils, right? There are no basophils, at least in these images, what I showed you. Fine. I don't have a basophil. So I am more in favor of leukemoid reaction. And osmosis gave us one more clue as well. They said there were more granules. Can I say more amount of granules as toxic granulations? Is that a finding as well? Yes, that's a finding, right? Toxic granulations is also a finding which is classically seen in leukemoid reaction and not seen in CML, right? We have lots of differential diagnosis between CML and leukemoid reaction before going to lab score. Right? Lab score is required theoretically. In a real life, we don't do a lab score. I'll go clinically, right? The first finding obviously is clinical evaluation. A patient with leukemoid reaction will be having sepsis. So I'm sure any undergrad can differentiate a patient with sepsis from a patient with CML. CML will have a classical symptom of a a massive spleen, massively enlarged spleen. That's what, and maybe cytopenias and leukocytosis. That's all. Maybe the maximum presentation or a dragging sensation in the right upper quadrant. Sepsis is totally different. Fever, sick patient. So definitely, I'm going to think of leukemia interaction. That's the first thing. Before even looking at the lab score, I have easily available clinical information. I'm going to look for that. Second, I look at the microscope. Like I said, basophils is something which is present. It's suggestive of a CML. That's a very characteristic finding. And here for leukemia reaction, since it is an infection, a heightened form of infection, I will see all the WBC stages suggestive of an infection, like toxic granulations. The toxic granulations are nothing but a very dense granulation, which means my neutrophil is functioning more faster and more efficiently. They need more MPO, more reactive oxygen species, have more granulations, right? So when I say toxic granulations are nothing but increase in the acidophilic granules, which means enzymes, which means my nucleus should work more, produce more. Right? So if you have to produce more amount of granules, more amount of enzymes, can I say my endoplasmic reticulum should function more? That's straightforward, right? If my endoplasmic reticulum functions more, they also will be seen prominently under the microscopy. That will be called as an Dole bodies. Dole bodies are nothing but pale blue dilated endoplasmic reticulum because they function more because to produce enough amount of my toxic granulations, right? I think there might be have been a Dole body here as well. Not sure if I can pick it up. I should have gotten a different picture, but still, if you it's not a best picture, I'll show you Dole bodies. I've seen few Dole bodies. Can you see that close to the corner, there's a little bit of a pink color condensation? Though it's not the best Dole body, I'll definitely show you better Dole bodies. And here, look at this. There's a little bit of condensation of some pink color material, right? Actually, Dole body will be slightly bluish in color. This is a Jeansa stain, so it kind of looks different. It's not a it's not a Leishman stain, so it looks a bit different, right? But Dole bodies in a Leishman stain are bluish color, dilated endoplasmic reticulum, which will be seen close to the membrane most of the time, right? Okay. So first thing, as I said, I want to look for a microscopy. Then only I'll go for lab score. So when I see findings suggestive of inflammation or infection, I think of leukemia reaction. Basophils, I'm going to think of your CML, fine. Okay, next comes my lab score. Lab stands for leukocyte alkaline phosphatase, which is again a normal granule content, right? Of these two things, where do you think I have normal neutrophils? Leukemia reaction or CML? In which condition do we see normal neutrophils? Obviously, I'm going to see normal neutrophils in case of a leukemia reaction. And rightly said, there are more number of toxic granulations. So can I say leukocyte alkaline phosphatase, which is a component of toxic granulation, will be expressed more, right? I'll have more amount of leukocyte alkaline phosphatase because it's a completely normal neutrophil with increase in granules. We have more increase in granules and a normal neutrophil. Obviously, my leukocyte alkaline phosphatase will be elevated in case of a leukemia reaction. But here, since they are mutated abnormal neutrophils, neoplastic cells, I'll have close to zero or reduced leukocyte alkaline phosphatase. This is lab score, fine. These are classical differences. If I'm not able to differentiate even by this, the last resort for me is BCR-ABL. Do a PCR or a karyotyping on a fish to prove it's BCR-ABL positive and BCR-ABL negative, right? That might not be required. Generally, in real life, it should be more than enough for me. And the microscope is basophilia present or not, that also is more than enough for us to differentiate them, right? Okay, one more case. Let's see if you can pick it up. It's not, I want very simple findings here. First, if you can tell me what biopsy is this? Just tell me what biopsy is this. That should be more than enough. What biopsy is this? Any comments? Endometrial biopsy, right? Deshmukh, okay, Satvik, CML variant or an atypical CML will have totally a different symptoms, different microscopic appearance, right? They will not be a differential diagnosis of leukemia reaction where dysbiosis should be more and I have more other findings. So atypical CML is not a differential diagnosis of leukemia reaction. A classical CML might be a differential diagnosis for a leukemia reaction, right? Okay. This is an endometrial biopsy, right? It's endometrial something called a pipal biopsy, where you have a linear core of endometrial tissue rather than a curetix, right? So here, if you look at this part, what do you think is the normal gland to stroma ratio in an endometrium? The normal gland to stroma ratio in endometrium, what is that? In a normal endometrium, gland to stroma ratio is 1:1, which means when I have one volume of gland, I should have equal volume of stroma, right? I'll highlight two areas here. In these two areas, can I say the kind of the gland to stroma ratio is maintained, right? In calling that, there's good amount of glands and there's good amount of stroma as well, right? Definitely there's good amount of gland and good amount of stroma, fine. So this part is okay for me. But if I go a little bit on the top, in this part, can you comment on the gland to stroma ratio, whatever I highlighted red color? Is there any alteration in the gland to stroma ratio first? If so, in favor of what? Are there more glands or are there more stroma? There are more glands or more stroma? They're big glands, and I'm sure there are more number of glands as well, right? The amount of stroma is reduced, right? So any biopsy of the endometrium, when you see like this, more number of glands and less number of stroma, when the gland to stroma ratio is skewing towards glands, my first diagnosis, I'm going to think of an hyperplasia, right? So let's go to the same thing in a bigger appearance. Can I say here there's more number of glands here? When there are increased glands in an endometrial biopsy, I'm going to think of an endometrial hyperplasia. There are terms for a pathologist to report whether it's with ATP or without ATP. That's totally different. So as of now, we'll just pick up endometrial hyperplasia alone, right? In this biopsy or in this image, it's a high power cut of the same thing. You do accept there's more number of glands, right? There's definitely more number of glands compared to the stroma. The classical case of endometrial hyperplasia. Actually, there's one more finding here. I put this particular image for that finding. Let's see if you can pick it up. Deshmukh, if you're still there, I would say restrain from telling the finding. I know you're a postgraduate. There's more for undergraduates. If want, I can highlight a little bit what I want you to look for. I want you to look for this place. I want you to look for this place. There's something which is very, very striking in the lumen. Can you comment what you see? And if you can comment what you see, I'll definitely help you to come to a differential diagnosis. What is there in the lumen? What is there in the epithelium, which is not ideally seen in case of an endometrium? Anyone? Any comments? Okay, is there anything like a brush border seen on the epithelial surface? Not trichomonas. Can I say that there's something like a brush border seen on the epithelial surface? Yes. So this type of epithelium in the female genital tract, where will you see? Well, this type of epithelium will be seen in cervix, vagina, endometrium, or tubes. You do have villus-like projections, right? So where will you see in the female genital tract this exact epithelium? Let's call them microvilli. Where do you see them? Can I say fallopian tube, right? Perfect. So this is an endometrial biopsy, which is having, like what Osmal said, a fallopian tube type of an epithelium. So what will you call it? Can you name this? You already know that. You must have read this in different places. I just want you to apply whatever you read to this place and name this, that's all. Okay, I'll give you one more clue. It's one adult mature epithelium, which is endometrial epithelium, glandular epithelium, which is changing to one more adult mature epithelium, which is your ciliated fallopian tube epithelium. So what will I call this? Tubalization is good, but this change, we have a better name, right? Can I call this a tubal metaplasia? You can, right? You know that. I just want you to apply that. See, you should not restrict it with whatever you learn, right? We learned metaplasia with Barrett's or maybe smoking related, but anywhere in my body, one epithelium can change to other. So this is a classical example for a tubal metaplasia, right? It's a new finding for you, but it's definitely, it's not very uncommon for a pathologist to see tubal metaplasia. It's quite a common finding seen in endometrial glands. So this case has endometrial hyperplasia with tubal metaplasia. This is reported as without atypia. That will not required for you to differentiate whether with atypia or without atypia. But tubal metaplasia, if you can pick up, that will be great. Okay, this is, I will come to the case number 9 later. We'll go through this. This is from Robbins. So comment on these 3 sections. If you have seen Robbins, I'm sure you can pick this up. First, tell me what organ is it. If you can pick up the organ, tell me what organ. Otherwise, I'll give you a clue of the organ. Then tell me the diagnosis. What organ do you think it is? Okay, if you cannot pick up the organ, I'll give you the organ here. Let's say that this is adrenal gland. Which one, Satvik, being choristoma? The tubal metaplasia, that one? This is an adrenal gland. The tubal metaplasia cannot be a choristoma because to call it a choristoma, I should have an ectopic crest. Right? It should be ectopic crest of something unrelated. Fallopian tube and endometrium is very, very close. So that concept of choristoma will never come there. When it is totally unrelated, see the definition of choristoma is separated, independent, and far apart. The best example is Meckel's, right? Gastric tissue and pancreatic tissue, which is not even related to ileum, can go to the ileum and do its function. That's what is a classical example of choristoma, which will not fit here because it's very, very close. It's definitely a simple metaplasia, right? I cannot call just an epithelial change a choristoma. I should have an entire tissue there. To call it a choristoma, it's not just the gland should change, gastric tissue will change, the gland, stroma, everything changes, right? Then I can call it a choristoma, right? Okay. Then adrenal gland. And if you look at this cell, can I call this atypical cell or not? Can I call this atypia or not? I can call this atypia. Definitely it looks huge. I know you'll come to endometriosis. I thought that you'll come to endometriosis next. I'll explain endometriosis. Finishing this, we'll explain endometriosis for sure. This is definitely an atypical cell, right? So can I call this pheochromocytoma malignant? It's a gross image of pheochromocytoma, and I have a microscopy there with a very huge nuclei. Can I call this pheochromocytoma malignant or not? I cannot call this pheochromocytoma malignant, right? You must have definitely learned this phrase. To call a pheochromocytoma malignant, what is required? Is atypia mitosis enough to call a pheochromocytoma malignant, or that's not enough? A pheochromocytoma can be called malignant in only one situation, only when you document metastasis. Only when you have a documented metastasis, I can call it malignant. Otherwise, I'm not going to call it a malignant. Fine. Otherwise, I cannot call it a malignant. Fine. Its invasion also is not acceptable for pheochromocytoma. I should have metastasis for pheochromocytoma to call it malignant. There are two places where only on documentation of metastasis you can call it malignant. One is pheochromocytoma. The other one is pituitary adenoma. In a pituitary adenoma also, I should have metastasis to call it malignant, right? Now let's understand why this is required, why this is must for me. Because this is not the case for any other body organs, right? Only in this place it's a bit special, right? What do you think is common to these two things, adrenal and pituitary? What is common to both? What is common to both adrenal gland and pituitary? There's one linking point towards adrenal and pituitary. What is that? There's one common point between adrenal and pituitary. Both of them are endocrine glands, right? Both are endocrine glands. That's a common point there. So when I have an endocrine gland, can I say for you, let's take thyroid. Your thyroid will have constant stimulation. The endocrine, right? They'll have constant stimulation, right? Like it's based on my requirement. It's based on my requirement, my thyroid or any endocrine gland. Let's take pancreas. I'm going to eat a little bit more. My beta cells becomes more active, secretes more glucose. I'm going to starve. It's going to totally get haywirely. It's going to change. So based on the metabolism of a person, every endocrine organ should be able to excessively produce an molecule. At the same time, be very quiet as well. This is very, very characteristic of every endocrine organ. So can I say, even in normal scenario, I might have big cells because they need to produce more and they become quiet. More amount of growth factor, it grows suddenly and again becomes quiet. So there's a concept called as endocrine atypia. So endocrine atypia is a common finding. Right? This is common for every endocrine organ. Due to constant stimulation, even a normal endocrine organ can have atypia. That's the reason most of the endocrine organs, if you look, thyroid, when I call papillary carcinoma thyroid, you read about orphan Annie, the papillae. Follicular, I wanted invasion, I wanted metastasis. Medullary, I looked at amyloid. I never talked about atypia except for anaplastic carcinoma. I need some other finding. I'm not relying on the classical signs of metaplasia, which is high NC ratio, your loss of polarity, mitose and everything. The same for my pheochromocytoma. I cannot rely on anything. Same for pituitary. For most of the endocrine organs, atypia is normal. That's the reason I either want metastasis or an invasion to prove it is malignant or not, right? That's a very, very classical finding for every endocrine organ, right? So when I say that, there's an electron microscopic image as well. What do you see in this electron microscopic image? There's a very classical finding seen in this electron microscopic image. What is that? What's the finding seen there? It's mutual osmosis. It's not one person is dependent. Perfect. That's a classical case of a neurosecretory granules, right? I think this INACT had a question based on this. It's neurosecretory granules. So can I say neurosecretory granules is a finding seen in every neuroendocrine tumors? These are called as perfect neurosecretory granules, right? So can a small cell carcinoma have the same finding? They can. Pituitary adenoma, same finding. Pheochromocytoma, same finding. Medullary carcinoma thyroid, same finding. Anything which has secretory granules in the tumor component, they will have the same electron microscopic finding. These are just secretory granules on an electron microscopy. Black color granules are very, very classical for all the tumors which I have named above, right? Okay. This is Potter. Let's see if we can pick it up. This is from Robbins. It's not my case. Comment on whatever comes to your mind. What organ is this first? Any comment on the organ? Uterus. Great. Uterus, you can see the fallopian tube and it's a cut open uterus. If you have identified its uterus, your diagnosis is simple. What do you think is your diagnosis? It's definitely uterus. The diagnosis here. Okay. This is the second image. Diagnosis based on the image. It's a classical thing. What happened? It's a very classical finding. No, it's not fibroid. What are these? Fatigue, is it? We'll finish in 10 seconds. It's 10 minutes. No, it's not endometrial carcinoma. It's a very classical finding. Okay, let me go back to the gross appearance again. No. Okay, I'll give you history. The patient had a uterine size which is more than the period of gestation. And ultrasonogram revealed tiny clear vesicles. And the gross image also allow multiple tiny closely packed vesicles. What are these? Great. Okay, now look at the microscopy. Can this be villi? Is it possible to be a villi? Is right. Great. That's an identiform mode, right? That's a classical case of an identiform mode. Gestation tropoplastic neoplasm, most likely in molar pregnancy, right? That's most likely a molar pregnancy, most likely in H molar pregnancy, right? Most likely a complete mode, could be a partial mode as well. What is the difference between complete and partial mode based on the pathogenesis? Which will have more fetal parts, complete mode or a partial mode? Which you think will have more fetal parts? A partial molar pregnancy will have fetal parts, right? Let's have a quick look about the difference between a complete molar pregnancy and a partial molar pregnancy. There are differences based on the pathogenesis, the appearance or absence or presence of fetal parts, immunohistochemistry, right? There are multiple differences. We'll have a quick look about it. Complete molar pregnancy will have 46 chromosomes. Partial molar pregnancy is generally triploid. You'll have 69 chromosomes, right? Of these 46 chromosomes in a complete molar pregnancy, they come from the maternal side or the paternal side. In a complete molar pregnancy, it's coming from the maternal side or the paternal side. You know that it's a very simple one. In complete molar pregnancy, it's always from its diandric, right? It's an empty ovum and it's going to be two, both of them is going to be contributed by the paternal side, right? It's paternal chromosomes which will fuse with an empty ovum. Always will be empty ovum. Either there will be chromosomal duplication or two sperms fuse them, fine. On the other hand, a partial molar pregnancy will have both maternal component and paternal component. That's why we have 69 chromosomes, right? A complete molar pregnancy, it has no ovum at all, no female component at all. They can never survive. They can never even form any fetal part because nothing but sperms. Right? It's only one person's genotype. It cannot form a zygote. It cannot do anything, right? So here, there will never be a fetal parts. But in a partial molar pregnancy, I have both paternal and maternal component, but there's a discordance. I have a little bit more excess of one component. So it will end up in abortion, but I will have fetal parts. When I say fetal parts, it could be gross fetal parts like a finger or anything, or sometimes microscopy as well. Fetal parts will be visible. If it's gross, it's not a difficult diagnosis for me at all. I can easily pick it up. But if it's a microscopic fetal part, what I have to look for it is NRBCs. If you see in the microscopy, nucleated RBCs, It's a very classical diagnosis for a partial molar pregnancy because nucleated RBCs seen in a molar pregnancy, which means fetal erythropoiesis has started. Because mother's RBC will not be nucleated in the placenta, right? Here, which means this is equivalent to fetal erythropoiesis. The placenta has started fetal erythropoiesis, means there is definitely a fetal part. So that's also finding suggestive of a fetal part, which helps me to diagnose a partial molar pregnancy. Okay? Next, immunohistochemistry. If at all I have a difficulty in diagnosis, if at all I have a difficulty in diagnosis, I'm going to go for an IHC to help me to come to a diagnosis. The IHC, like Satvik said, I'm going to go for an IHC called as P57. I'll give you the base of P57. You tell me in which it will be positive, in complete or partial molar pregnancy. P57 is a protein which is expressed from the maternal side. For you and me, chromosome of P57, only from the mom side, it will be active. So in which of these two do you think P57 will be positive or it will be expressed? Only the mom side P57 will be active for every human being. So in which of these two it will be positive? There's only one molar pregnancy which can have the maternal component, which is partial molar pregnancy, and P57 will be positive only in a partial molar pregnancy, and P57 has to be negative in case of a complete molar pregnancy because there is no maternal component at all. Since there's no maternal component, it's completely negative, right? Most of the time, partial to complete molar pregnancy, I'll be able to differentiate based on your microscopy and P57. If it is not possible to differentiate, you might require karyotyping as well to some extent to see whether it's 46 or 69 chromosomes. That will help you also at some point of time to differentiate that. Fine. Okay. I wanted to show you one more case. This is a case from our lab. This is not classical one. Maybe let's see if we can pick it up. Just 2 minutes. I'll end. A very, very long session, right? So this is a bladder biopsy. Okay. Comment on whatever you're seeing. Infection or inflammation. We'll start as simple as that. Bladder biopsy, infection or inflammation. It's an inflammatory disorder, right? Because I have lots of WBCs, most likely lymphocytes. When I have lots of lymphocytes like this, I'm going to think of an acute inflammation or a chronic inflammation. We'll definitely think of a chronic inflammation, right? It's a chronic inflammatory process, that's all. The chronic inflammatory process here. Okay, I'm going to zoom in a little bit. Can you pick up anything unique in this image? That is actually unique finding. I am not sure if you are able to pick it up very classically. This is something which is unique. This is something which is unique. I have a little bit of here as well. Any comment on this? I think this kind of came in your exam recently as well. I do have some blue dots somewhere and somewhere rarefied material here. I should have taken a better picture, but still. I'll give you a clue that there are a little bit of calcification seen here and there in a bladder with lots of these cells. These are all foamy histiocytes. Okay, these are all foamy histiocytes, and I do see a little bit of blotches of bluish rarefied material here and there. I have foamy histiocytes, I have lymphocytes, and I have calcific material in a case of bladder biopsy with chronic inflammation. All of them checks only one disease. What is that? A chronic inflammation. Perfect. We'll have increase in foamy macrophages and we'll have increase in calcification inside the foamy macrophages. As I said, though I didn't pick up a best image, but that's a case of malakoplakia. This is your Michaelis Gutman bodies. Do remember them. Okay. This is a classical case of a malakoplakia. I just want to complete that since I put the case on. That's all. Do remember about malakoplakia. In malakoplakia, I'll have a defect in the immune system. My immune system is not going to work too perfectly. So it's going to kind of Let even an E. coli or a Klebsiella retain there for longer time. Repeated infection results in chronic inflammation, and you have tissue destruction mediated dystrophic calcification. Okay. Well, come and end to this. It was a little bit of an exhaustive session for me and as well as for you. I hope you enjoyed it. And if you have any doubts, do let me know at any point of time. Now let's try and learn a little bit outside your exam perspective. It's not always MCQs, right? I want you guys to send out your thought process outside. Imagine, come to various differential diagnosis. We'll make mistakes. We'll learn more, not just in the form of MCQs, right? I'll have an entire session of interesting case discussions. I'll keep uploading 1 case or 2 cases per day, so that I just want you to observe them and just make whatever diagnosis comes to your mind. Fine. Glad you liked it, osmosis. Fine. Thank you for your time. Have a good night and a great June month. Fine. Thank you. Bye bye.